Bonjour à tous. Merci à Guy et aux équipes de nous réunir à nouveau physiquement. Je suis ravi d'avoir l'opportunité d'animer aujourd'hui ce débat sur un des sujets les plus essentiels, mais à mon sens aussi des plus difficiles à appréhender quand on parle de santé. On va pas débattre de l'importance de la prévention. Je pense que personne n'est à convaincre dans cette salle. Je pense aussi qu'on est tous convaincus qu'on n'en fait pas assez. Ce que je vous propose, c'est vraiment qu'on réfléchisse à comment est-ce qu'on peut vraiment accélérer encore, faire plus, faire mieux. Qui doit-on mobiliser pour cela et comment est-ce qu'on mobilise les acteurs qui sont nécessaires. Aurélien Rousseau parlait tout à l'heure de coalition. Comment est-ce qu'on mobilise les coalitions? Comment est-ce qu'on est dans le quotidien des citoyens pour réussir à vraiment avoir un impact sur cette action de prévention. Alors c'est un sujet qui est très large. Ce que je vous propose, c'est qu'on le prenne par cercle concentrique. En commençant par parler de la prévention secondaire, et donc de la prise en charge des malades chroniques, qui est un domaine dans lequel on a encore, par rapport à un certain nombre de pays voisins, des progrès substantiels à faire en France. Donc, comment est-ce qu'on peut y arriver? Et puis ensuite, on s'intéressera aux facteurs de risque en élargissant, en parlant des comportements humains à risque, de l'environnement de vie direct, et puis de l'environnement au sens plus large, santé animale, environnement. Et du coup, peut-être pour commencer, et pour parler de prévention secondaire, je vais me tourner vers Marguerite. En tant que médecin, de votre point de vue, comment est-ce qu'on peut améliorer la prise en charge des patients chroniques dans notre pays?
Alors, merci de me permettre de parler de cette question qui en fait est au cœur de notre exercice en tant que médecin généraliste. Ça fait 30 ans que je suis installée et en 30 ans j'ai vu l'évolution d'une médecine curative, on est vraiment allé vers une médecine plus préventive avec une augmentation des patients avec des pathologies chroniques. Ce dont les patients qui ont des pathologies chroniques ont le plus besoin, c'est de temps. Or, ce dont les médecins manquent, c'est du temps. Donc, effectivement, is lacking for doctors is time. So it's somewhat paradoxical. In this framework, I've been lucky enough to be able to benefit from the fact that I was working with a nurse delegated to public health and therapeutical education, and we looked at a new protocol 7 or 8 years ago, and it changed completely my practice. And then also recently, I introduced a medical assistant who takes care of the file of the patient, supporting their journey, because it's a real difficult journey when they want to get an appointment at a specialist, an ophthalmologist or whatever. What does the nurse do? The nurse gives time to the patient to try so that the patient understands the disease and becomes autonomous, because the objective is to make these patients autonomous and for a while. So, this is an experience I've led, and I believe it has changed a lot of things. I can see small miracles every time. And because it has an impact on patients, but also groups of patients, and this changes behaviors and helps people evolve. So it's one of the paths I've explored, and that has shown to be efficient. Any more experiences?
Ce type de démarche, on peut s'assurer qu'au fond, elle prenne, elle se généralise. Qu'est-ce qui fait que voilà, aujourd'hui, on a peut-être plus de ça que précédemment. Peut-être Frédéric, l'hôpital est de plus en plus engagé aussi dans ces démarches-là. Peut-être tu nous parlais de démarches de santé populationnelle que vous avez commencé à expérimenter.
L'hôpital, de façon par nature et par principe, il a vocation à être structurant et à travailler le plus largement possible. Au-delà de ses missions de plateau technique et de recours, il a aussi vocation, et on le voit dans de plus en plus de territoires, à travailler avec la médecine de ville. De ce point de vue-là, la création des communautés professionnelles des territoires de santé, les CPTS, permet aussi maintenant d'avoir des interlocuteurs structurés et d'entamer des dialogues qui, dans certains territoires, sont déjà très mûrs et très avancés. Tu évoques effectivement une démarche qui a été poussée par la Fédération hospitalière de France il y a quelques années et autorisé par
French
un
Hospital
amendement
Federation
à PLFSS il y a 3 ans,
started a
qui
few
était
years ago.
une démarche de responsabilité populationnelle,
It was
c'est-à-dire
an approach of
de démontrer par la preuve
responsibility to the
que quand on laisse
population,
faire les
i.e.
acteurs sur le territoire,
showing the proof that if you
sur des
let
sujets précis, en
stakeholders
l'occurrence, ça
develop
concerne
on
5
the
territoires
territory for
sur 2
specific topics,
pathologies,
we're
le
talking
diabète
about
et les
5
maladies
locations
cardiovasculaires.
for
Quand on
2
laisse faire les
pathologies,
acteurs pour inventer
diabetes
des réponses les
and
plus adaptées
cardiovascular
et aux caractéristiques de santé des habitants du territoire.
They can
Mais aussi
adapt
à ce
to
qu'est
the
l'offre de soins sur
specificities
chacun
of
de ces
the
enfants.
community
Eh bien,
and the
on
offer
peut
of
avoir des
care,
réponses qui sont
etc.
certes
And
très
you
différentes
realize that
entre
you can
Douai,
get
Niort,
answers that are
Troyes,
very different
Quimper,
depending on the city,
et
Douai,
j'oublie le
Niort, Quimper,
qui seront
Troyes,
peut-être très différentes à
I can't
l'arrivée,
remember
mais
which the
qui
fifth one was.
permettront quand
And
même
you can have
d'avoir
results that are
des
very
solutions
different
adaptées derrière
in
tout
the
ça.
end, but will give
Il y
you
a-
solutions all the same.
Alors, comment ça fonctionne? Depuis
How does it
2-3
work?
ans,
Well, for the
on a
past
mis
2-3 years,
autour de la table tous ceux qui,
we
sur
have
ces 2
seated
types de
around the
patients, de
table,
filières,
all the people at
sont
stake
intervenants
for
depuis
these
l'hôpital
2
jusqu'à
types of
effectivement des
patients,
acteurs
from the
collectivités locales,
hospital to local
paramédicaux, libéraux,
communities,
bien sûr,
paramedical
donc tous ceux qui
practitioners,
sont partie
liberal
prenante, j'allais dire, du suivi
GPs,
de ces patients,
all the people
pour
who
essayer
can follow
d'améliorer
these patients
l'efficacité de la prise
in
en charge
order to
collective.
improve
Et à
the
l'arrivée, d'avoir des
efficacy
indicateurs
of
qui ont
the
été
collective
définis
care,
avant, de manière à ce qu'on puisse
and
mesurer
end
l'avant
up
et
with
l'après, parce que évidemment, ça n'a
indicators that
d'intérêt
can
que si
help
on
us
mesure
measure
cette
before and
efficacité
after,
dans la mesure,
because otherwise it's not very
effectivement,
interesting if you can't
que les
measure.
solutions mises en œuvre sont des
So
solutions qui
they
sont
enable you
pertinentes,
to see that all the
plus
solutions
fluides,
that are introduced are
mieux huilées
pertinent,
entre les uns et
more
les autres.
fluid,
Derrière ça et derrière cette petite
and work better.
expérimentation, on fonde beaucoup d'espoir, on est nombreux à fonder beaucoup
We have
d'espoir
a
de
lot
pouvoir
of
démontrer
efforts,
que finalement,
a
si
lot
on
of
faisait
hope
faire une
based on
révolution
this,
copernicienne à notre système de
thinking
santé,
that if
qui
you
fasse beaucoup plus
give our health
confiance
system a
aux acteurs de
Copernican
terrain pour
revolution
élaborer des
and you
réponses,
trust more
sans
the
doute que
actors
tout le
in
monde
the
s'en
field
sortira mieux et au-delà de
to
certains
design
territoires,
the
bien sûr, et
answers,
au-delà de ces deux
then
pathologies.
everybody will feel
Donc,
better
c'est
and
une
will
espèce de
do better
démonstration par la preuve,
above and
qui est
beyond
un
the
peu longue à monter
pathologies.
parce que,
So it's a demonstration that is
on change
difficult
un peu les
to
habitudes, mais qui est très prometteuse. On va dans les
set
prochains mois
up,
publier un
and
premier
because
bilan.
you're
On
changing
est
people's
accompagné par des
habits, we're going
universitaires,
to
on est
publish
accompagné
a
par des gens
first
qui viennent
report
aussi
in a few
aider
months
les
with the
acteurs
help
locaux
of
pour bien
the academia.
cette démarche puisse être mesurée. Et le rêve, mais bon, je ne sais pas le lieu d'en parler maintenant, mais le rêve de tout ça, ça serait effectivement un système de santé où finalement l'État définirait des objectifs, et pour faire très vite et très court, et les acteurs de terrain, finalement, définiraient le chemin qui permet d'aller de la situation à l'objectif qui est fixé, c'est-à-dire en fait à améliorer la prise en charge de la population.
Avec ce que je retiens, cette notion de dire il faut que chaque solution soit adaptée à son territoire. Peut-être d'autres expériences comme ça sur
local territory. Any more experiences like this,
L'expérience de la mutualité sociale agricole aussi.
I can give you my experience of the
L'éducation thérapeutique
agricultural
notamment, c'est un
social
axe fort de
mutual
notre politique institutionnelle.
insurance.
Donc,
The therapeutical access is very
une
important
population
in
qui est plutôt vieillissante.
policy. We
Dans
are
le cadre de
talking
la
about
population
an aging
agricole,
population in
puisque les
the
constats qui ont été
agricultural
faits,
world,
c'est qu'on a une
because
population qui est
our
presque 10 ans plus
population
âgée que la
is
population
almost
générale,
10
et avec
years older than the
21%
general
de nos
population,
assurés qui sont en
and
affection longue
21%
durée.
of
Donc, on voit, il y a un véritable enjeu
people
aussi pour nous,
have a
effectivement,
long-term
à accompagner ces
affection,
pathologies
so
chroniques,
we have to
justement,
support these
peut-être par
chronic
cette approche, par
pathologies,
l'éducation thérapeutique
and
qui permet
maybe through
aux personnes d'acquérir une
therapeutical
meilleure
education that
compétence
will
finalement
give
dans la
people
gestion de leur
more
maladie,
competencies,
grâce à des règles d'observance
more,
thérapeutique, des règles
tools
hygiéno-diététiques, des règles d'autosurveillance
manage
que
their
les personnes
disease
effectivement apprennent
through
à
some
développer
rules,
individuellement.
self-surveillance
Donc
elements
voilà,
that
pour nous c'est un
they
axe
can develop by
effectivement
themselves.
extrêmement important.
So to us this
On
is very
agit aussi plutôt sur des
important.
territoires ruraux, de par
We
notre
are
spécificité,
working
donc sur des
mainly
territoires
in
qui sont
rural
plutôt loin
areas by definition.
des grandes villes, qui n'ont pas forcément
So
un
we are
accès aux
far
soins
from big cities.
optimal.
Do not
C'est aussi une façon,
necessarily
voilà,
have an
acteurs que vous
access
mobilisez
to the best
là-dedans,
treatment.
c'est qui?
And
Alors,
who
on
are
mobilise, on
the
travaille avec de
stakeholders
nombreux
that you're
partenaires,
mobilizing to
dont
work
certains,
like that?
effectivement, se
Well, we
retrouvent
work with
autour de
many
cette table.
partners.
On
Some of
travaille
them
avec
are here.
les maisons de santé
We work
pluriprofessionnelles,
with
notamment toutes les structures
the health
d'exercice coordonné, qui
establishments,
sont
all
des
these
vecteurs
structures of
pour nous extrêmement
coordinated practice.
importants pour accompagner le
And
programme. On travaille avec des réseaux de santé.
we work
On a la chance, donc, dans la
with
région je viens, donc la région Grand Est,
health networks in the region where I am, in the greater eastern region, we have quite a lot of networks on metabological diseases, geriatrics, etc. So we have partners that can support us to develop these local programs, and we also take part in their training to therapeutical
j'espère réussir un réseau de santé autour de l'enfant obèse,
pediatrician, and for the past years I've tried to develop a health network for obese children. So when you look at history, you have to understand the hindrances and difficulties. The first one is to relate the world of city, hospital, prevention health for children and schools. And historically, these people don't know each other. So we have a lot of trouble, even though people might have the same training in the start. They end up with a culture that is very different from what they see in daily life. And the interpenetration of these cultures can lead to conflicts. Secondly, we've seen the evolution of before the ARS.
Qui avait proposé suite au réseau SIDA, en fait,
following the HIV/AIDS network, we've seen that it was difficult to structure this type of thing.
C'est d'abord que les gens se connaissent, et au départ, on a commencé par avoir un module commun de formation qui rassemblait tous les types d'exercices, les diététiciennes, les psychologues, tout le monde, pour avoir un langage commun petit à petit. Donc ça a porté plutôt ses fruits. Et la deuxième difficulté, c'est d'essayer de comprendre, quand nous sommes soignants, on ne comprend pas forcément le fonctionnement des financeurs, on ne comprend pas le fonctionnement de ce qui va être pérenne, de ce qui ne va pas être pérenne. Et quand on est président de réseau, c'est assez compliqué. Quand on a des budgets qui vont jusqu'à 1 million d'euros, d'essayer de tenir tout ça, donc il faut s'entourer de professionnalisme qu'on n'a pas forcément au début, mais qui petit à petit vient parce qu'on embauche effectivement des gens qui ont cette capacité que moi je n'ai pas. Voilà, en gros, pour les difficultés d'initiation, on pourra reparler du contenu après si vous le désirez.
Donc comment est-ce qu'au fond on crée une culture, une connaissance mutuelle, un dialogue, peut-être aussi de la donnée qui permet de rendre ce dialogue transparent. On a néanmoins, vous avez évoqué d'autres acteurs que des acteurs de soins, mais on a quand même beaucoup pour l'instant parlé des acteurs de soins. Si vous voulez bien, je propose qu'on élargisse du coup d'un cran le cercle et on se dit, au fond, pour être vraiment dans la prévention des comportements humains à risque, comment on doit faire et comment est-ce qu'on... Alors, oui, on mobilise le système de soins, mais comment aussi on arrive à mobiliser plus largement. Peut-être, Marc, vous pouvez nous partager votre expérience.
Oui, alors il y a deux niveaux, évidemment.
Well, there are two levels. Firstly, there's the healthcare, public health prevention level with
mais il reste toujours une dimension qui aujourd'hui est extrêmement compliquée.
But there's also another dimension that is much trickier in the area that I represent, which is suicide prevention. There is the intimacy of the act itself. Why do some people who belong to some groups that are deemed at risk do go on to commit suicide and why others don't? There's something a little bit mysterious there. And so prevention has to call on other systems. And what I would like to defend here is that in medicine, especially in the field of children and teenagers, you have a sort of an opposite system in terms of care. So there is the notion of the singular colleague, GP, with the care, but and that can be a blocking aspect, could stop things getting better, especially for children and teenagers. In order to do prevention, we have to go from a model that is centered on the person to a model centered on the ecosystem, on the living arrangement. So it's a much more ecological way of looking at things. So I'm a psychiatrist for teenagers at the Toulouse Hospital, and so I've worked
a lot, not necessarily with teenagers themselves, but through their families.
Nous avons là un modèle à la fois thérapeutique, mais de façon extrêmement conjointe, un modèle préventif, puisqu'on travaille avec différents membres de la famille, et on évite ce qu'on voit souvent dans certaines familles, c'est-à-dire le passage de situations pathologiques d'une personne à une autre. Parce que finalement, le travail se fait globalement, y compris avec les plus jeunes, y compris avec les parents qui, du coup, sont vraiment acteurs du soin.
And they become part of the care. And I think that this family therapy model is a model that should be spread to many other situations for prevention, for care, and in all fields of medicine and beyond. So, yeah, this is what I wanted to say.
Pour les enfants, compte aussi, puisqu'on est dans les collectivités territoriales,
as we are based in the different regions, it's also important where the person, where the child lives, especially
et des lieux sociaux qui permettent à
remote areas,
de pouvoir avoir un effet
like a social area where the child could be taken away from the family for certain duration. And it's the territories, the departments that can organize that, the local authorities at department or city level. And so this is a joint action. If we can ease this, it can really play a big role in terms of public health in this particular field. Regarding obesity, there was a report from the Global Institute recently that showed that if you want to have an impact at the systemic level, you needed to have a few dozen interventions quite broadly to mobilize the local authorities, the care system, the school restaurants, the food industry, the employers, and so on. What is your experience in this? And how can we succeed in mobilizing with this logic of local authorities? How can you mobilize all the different players? I think you need to analyze the territory you're working in, because you can't have the same response if you have very poor populations or if you have populations that have the means and have, if you have 5% of families who eat through soup kitchens, you can't tell them eat 5 fruit and veg a day. That's just impossible, even if it makes sense. So you have to analyze things, and you have to adapt the public health recommendations. Initially, we wanted to do well, and we had a program in kindergarten and in schools for the general public, and we realized it's the families who needed it least that benefited from these programs. So you have to understand that you have to adapt to the population that you're faced with, and so it's important to do an analysis. That's what happens with the local health contracts that have been developed by the ARS recently, and they are active in a lot of towns and cities, and you analyze the territory, and then you can choose what to develop, and there are different things to do for children. So localized solutions. Yes, localize it and understand the territory where you're working. And the smaller the territory, the easier it is. The more you're looking at a department or region, the harder it can become. I think there's one element that's very important. It's true that there are lots of prevention programs, networks, things like that. But the problem I see as a GP is the step between myself, when I meet my patient, and I feel there's a need, and the moment when they get to those workshops and so on. And that's where we see the difficulty. And when I worked with that nurse I was telling you about, who did a survey on the resources out there,
et en coopération avec moi très proche, ancre avec les différents dispositifs permet aux patients de l'amener à ces soins-là.
Patients get access to this type of care. And the big problem in our system is this gap, the gap you have between me, sort of the first point of call, and the other places. And this gap is the one that we have to work on. So we have to rethink the first level, the first point of access. And I think that the system is suffering from this. We have to rearm the level of first access. I have done that, and now I can give a proper response for the patients on the different resources out there. I think we do have the resources in the at department level, at city level, but the GPs often don't know about it. I just wanted to add something to this. I quite agree on the adaptation to the territory. They're not all the same. You were talking about patients earlier. It's the same for vets. We see the same with pets or animals. For many of them, their pets are family members, and they basically reveal the mental health, in a way, of their owners. And I think that we don't talk enough between doctors and vets on the signs that you can detect on the animal and that could lead to certain symptoms that could indicate that something is going on in a family. There is a law that is under discussion on animal mistreatment and the link between animal and human mistreatment. But the animal can be a mediator in a way and can provide solutions for their masters. We'll have a look at the notion of family circle and the importance of what you highlight here. Coming back to what you were saying, what should be changed is really the role of public authorities as guides on what could be done depending on the current context. As a supporting role on the different territories, we can only put in place a program from the moment that that it doesn't go against what is already out there. Lots of programs have worked really well in some places, and then we try to copy-paste them elsewhere, and they just don't work, because culturally they're not compatible. So even if it's a microculture, so we have to create things from the demand and the potential offers you can have at local level. We'll come back to what role there can be for the state here. But before that, Frédéric, what about social factors? These are essential in the population's mental health, especially. So as a mayor, how do you think of this and how do you take it into consideration? Well, I think that from everything that we've been saying, the local level,
est un niveau autour duquel il y a beaucoup de choses à faire, parce que c'est
shows that there's lots to be done there. That's the basis. Then there are lots of big programs, big
là où on veut
funds and so on,
essayer
big
d'être
targets,
efficace
but where we want to be efficient to analyze and to spot the weak signals before problems arise, whether it's a person who might be suicidal, a problem with a family, whatever the problem. It's true that it's by having the opportunity to talk together, and there are still some blocking points. I think Mr. Chevènement, when he was Minister of the Interior, that was a while ago now, tried to put in place some local safety committees.
De police et de répression peuvent discuter aussi
avec
les services sociaux et partager leurs informations.
Could talk with social services. Well, that's all very good, but in the field, even years later, we're still very far from this. So there's a lot of steps, a lot of hurdles to go through so that we can better cross the information out there. And that's what's important. The mayor with the municipal services looks after children from the youngest age to, well, until people die, and then we manage the cemetery. So throughout all different stages of life, we meet people, we look after them, we know them.
de plus en plus, la population se tourne vers ça.
The population is turning towards the town hall, but we're not alone. We have to work with professionals, we have to work with different networks.
Peuvent permettre d'avoir des réponses qui sont ciselées.
Which means that we can have targeted answers.
Finalement, il n'y a pas d'études statistiques.
To answer your question, well, we don't have statistical surveys, so we know where the population lives.
A besoin d'être un peu plus accompagné que d'autres.
Especially the population that needs more support. We know through varied information there might be problems here and there, and it's by crossing all that, like crisscrossing that information, that we can build proper responses. And having talked with lots of different mayors, we have a very pragmatic way of looking at things.
Mais c'est vrai que la grande idée, c'est d'arriver à permettre
would be
se faire confiance, se connaître les uns les autres, se faire confiance,
know each other, trust each other, know the different initiatives at local level, and especially the initiative bringing different players together.
Des hommes et des femmes. Enfin, on a besoin de se connaître pour se faire
we
confiance,
need to know each other in order to trust each other. And then, when we have a problem, we know that we can call on you or on GPs because they are committed in whatever body as well, and that's how you can build answers. But you have to talk. It comes back to what you were saying earlier, saying that we have to have that common culture, and people have to know each other. Yes, and let me wrap up. Local authorities, and especially towns, are doing more and more prevention. I mean, I'm an old mayor now, but I've been a mayor for 12 years, and tomorrow we'll be starting Pink October on breast cancer. I can't remember what we're doing last month, but I was invited for the creation of the CPTS body, where I was invited by doctors. So there's lots and lots of dimensions, and we are more and more aware of this. And the notion of opening up to others is the same with all the different players. So I think the field of prevention can really feed from all this. Then, of course, you have to have strategies, you have to have rules for funds and so on. For local authorities, you also have the decentralizing laws that initially at least stopped everything. When we went to see the local authorities, we were asking them whether this was their scope or not. For regions, for instance, when they look in their finding text, they see very little. For town halls, in the text that in the targets, there is very little to do with healthcare. There was one which was checking vaccination for children. And then, of course, local authorities can take over a theme, but these are not opposable. So if you put in the law that the department has to do something, then of course they have to do it. But if it's up to the institutions, yes, it can give local dynamism, that's great, but as it's not compulsory, then there can be disparity between the different towns and the different local authorities. Just to add to what you were saying, and this is adding to supporting what you were saying, the towns have general competence. It's public money, so of course you have certain rules as to how to spend the money. But on the competence and knowing whether you can invest on suicide prevention or cultivate peas in the commons, for instance. But it's true that other local authorities have strict competence, but really you have to know that people do a little bit what they want, and you pile up everything. And with time, even if the department has strong competence, look after secondary school and roads, what department doesn't look after tourism as well? But anyway, this is quite another debate. But it's true that everybody can act on prevention. I'm a regional elected representative in the Île-de-France region. Many regions have started working on these topics, and it wasn't the case
remarque sur l'émergence des communautés professionnelles territoriales de santé,
on
qui en
the
fait
territorial
ont le mot
health
territoire,
authorities, you have territory, you have the healthcare authorities, and that brings together all professionals in one territory. And in their mission, they have preventative missions as well. And I think I'm the chairwoman of a CPTS in a poor constituency, and I've got a very strong link with my constituency and the other elected representatives. And they have a broad view of the problems and the social factors that can help me. And they know the needs, they know how healthcare professionals can help answer those needs. And I think that's an opportunity to improve the general health.
En ARS, la MSA,
we had some experience with the ARS, MSA as well, the coordinating doctor.
Cette approche, et c'est vrai qu'on voit qu'il y a des
yes, I second this. We see that there are multiple methodologies that provide competence that not everybody knows about. So it's true that it can be good to have a director to pull all this together. And we do have tools. You were talking about the local health contracts that mean that elected representatives can work together. You have local, territorial health authorities. So we all take part in this. So it's a way of putting a diagnosis on a territory, the strengths and weaknesses of the territory, not just on healthcare, by the way. It's also for social poverty and so on. It's a way of defining avenues for improving things at local level, especially for improving the livelihood of people. And then there's the second aspect for healthcare professionals. These are initially proximity healthcare professionals, and it was a great chance that was given not so long ago, 2 or 3 years ago. And it means that we identified this approach of recognizing municipal medicine, and it means that local players were able to work together. You also have hospitals. We were able to work with socio-medical partners in the different territories, also based on an analysis of the territory. And then we can develop some actions that are tailor-made.
Mais alors du coup, c'est qui est mieux placé pour être le chef d'orchestre? Est-ce que c'est le premier recours?
You're talking about the director, but who's the best director, as if you were an orchestra director? Who is in the best position to be the director?
Faut-il un chef d'orchestre ou
faut-il
des gens qui répètent ensemble et qui finalement, le chef d'orchestre, c'est très français de mettre toujours un chef. C'est peut-être ça aussi le problème, c'est qu'à un moment donné, en fonction quand on change de chef, on change de musique. Je pense que la question, c'est surtout de faire répéter les groupes de musiciens, de communautés
getting the musicians to rehearse together so that they
répètent ensemble.
all
Donc
play
c'est la
the
question
same
comment on fait répéter ensemble les collectivités territoriales, les comités professionnels de santé, les divers ressources du territoire, et comment avec tout ça on arrive à faire quelque chose d'efficient pour les patients, parce qu'on est quand même là au final pour la santé des patients, c'est-à-dire notre santé, la santé de nos enfants et l'avenir aussi de
take care of our children's health and the future of our planet. Marc? Yes, it's interesting because in France, and not only in France, we always have the feeling that somebody must be there to supervise, that there must be a boss. And we're actually freezing things by doing that. We need regulatory bodies. I mean, that's unavoidable because otherwise, if all the systems start moving in opposite directions, they might take orientations that will not be compatible. But we need somebody to supervise. However, if most of the time we allow things to simply happen, they would self-regulate. I'm not saying it's the best solution and that it fits all situations and it will allow us to face all our challenges. changes. But I believe that this is underutilized as a possible option. We say that everything needs to be done with rules. We need patients to sit on committees so that they can participate in the setting up of new systems. But simply because it cannot work if the patients are not there. It's like taking stock of the situation, social, psychological, biological. Everybody makes an assessment and we bring all the assessments together and we think we can, a situation will emerge, a solution will emerge. No, it doesn't work that way. It's when people sit around the table and that's when we find solutions because everybody contributes and each with their own skills and knowledge. You'll apologize me, I still believe that you have to have someone there, a conductor, a manager. I'll give you an example. The avian flu, which has had dramatic consequences in the southwest area of France, which is known for breeding ducks. Every time there is an incipient crisis, it turns into a number of ducks to be slaughtered. I mean, we need to come up with a model. The social ecosystem needs to identify the risk factors, the risks that need to be managed. We make a model and we say, okay, in a given situation, this is what we're supposed to do. And who takes the decision and who regulates. There is not a boss or a conductor for each situation. We need to map the areas, but we now know it because we've witnessed it during the COVID pandemic. There was a time when we simply did not know who was in charge, and so some people came under the limelight and thought they could, become the storytellers and replace the real scientists. In a crisis, the President of the Republic is there to manage and decide what is the rule and what must be done, and this must be applied in all the territories. Well, we need to discriminate between a normal situation. I mean, we're not there to learn to walk every day, and a crisis situation. And let me mention the COVID. The COVID is an unheard of situation. Well, there are situations that we could have predicted, but not this one. We could not foresee it. And we applied systems which were pre-established. Sometimes they simply failed. I work with families, and it happens all the time in the family. And when the family works well, there is a vertical organization, there is a boss, a father, and everything works well. But as soon as we walk out of the framework, everything goes wrong. Well, if we want to harmonize all the institutions, I would say that in France we had a failure. The fact that we are completely hospital-centered. In the last few years, we left the hospital at the very heart of the crisis, allowing the hospital to simply try and manage the situation. And because the hospital was in a dire situation, it tried to find funding elsewhere. And it was difficult to demonstrate that in spite of the fact that we are slowly going towards more outpatient or day hospital work rather than hospitalizing patients, this hospital-centered system is failing. I'm not saying that hospitals are useless. I'm saying that there comes a stage when the hospital is not competent, is not skilled enough, doesn't know what to do and doesn't do it better than you would. So if we want to have a conductor, then something is wrong. I'm not saying we need power just for the sake of power, but when the networks were structured, money was put on the table, hospitals were not doing well, they were trying to find funding, and so they went everywhere to find money. But that's why it was difficult between territories, institutions, and the central healthcare administration, and the way it is exercised.
toujours un peu tendance à tempérer
I'm always the one trying to mitigate accusations according to which in France we are very much hospital-centered.
Il ne fallait pas balayer devant la porte de l'hôpital.
I mean, I know we have to sweep in front of the hospital. I'm not saying that everything is going very well in our hospitals, but I see hospitals that really would like to be able to focus on their problems, who dream on being able to maybe organize prevention, local prevention, play their role in the effort to structure the way patients are managed.
Parfois que ne pèse pas aussi sur eux la crise malheureusement que vit la médecine libérale aujourd'hui.
They have to bear the burden of the crisis that community physicians are going through in France. All players in the healthcare system in France are having difficulties, and sometimes there is an overspill
c'est un peu une vieille lune
on
cette
the other
histoire
players in the
de
healthcare
discours
system.
sur l'hospitalo-centrisme
So, this whole story according to which we're very hospital-centered at the France and that is the origin of all of our problems, I don't really buy it.
Si la médecine de premier recours,
physicians working in hospital settings would be very happy if
puisse à nouveau retrouver sur tous les territoires
community physicians could play a real role again, that they would be the entrance door and the hospital would come next. The hospital should normally play a role at a certain stage, but not necessarily as the first contact point with the patient, and that should be the community physician. So maybe the mayor, could be, if not the boss, at least the facilitator, because the mayor carries some legitimacy over the territory. He's been elected, he doesn't know everything, he's not skilled in all fields, but at least he's in a position to bring together people who would not necessarily talk to each other if he weren't there to bring them together. So it's a small role, but it's a role that a mayor can play.
La paix en quelque sorte, c'était peut-être que la problématique se situe plus que l'hospitalo-centrisme, c'est aussi la question de la définition des missions et la gradation des soins, qui est peut-être pas assez définie dans notre pays. Soins de premier recours, soins de deuxième recours, soins de troisième recours, et chaque intervention. Et le niveau de soins de premier recours, je le redis, je suis dans mon rôle, qui n'a pas été assez musclé pour remplir ces missions, et des missions gonflent, et en même temps des modèles économiques qui ne sont pas adaptés et qui font qu'aujourd'hui, on a du mal à recruter dans le premier recours. Je crois que
ready for it, and we have trouble hiring people actually to play a role in the first line healthcare
rebondir sur ce qui a été dit.
system. I'd like to say two things. There's one word that we may not have used enough
peut-être même pas du tout. D'ailleurs,
so far,
le terme de parcours de santé, parcours de vie.
What we call in French the parcours de santé. It's a French idea to say that the patient has to follow a certain circuit, and we have to be there to serve this circuit, followed by the patient. In our French national strategy in the 2016 law, we see that this circuit is very, very strong. It actually brings us together around the patients, around the people that we care for in our territory. We all carry a certain responsibility at some stage of the circuit. And the second thing I wanted to say, maybe this will allow you to agree, rather than talking about an orchestra conductor, I see new jobs emerging on our territory, people who are called coordinators in multidisciplinary or multi-profession healthcare institutions, people who work together but have a different background. And we need to support them, help them work together. So I'm not really talking about a boss or a director or a conductor, but rather somebody who plays the role of a coordinator. And we see this all the time now in healthcare territory territorial institutions. He's like the Swiss knife that can do just about everything. He needs to have skills in legal matters, logistics. He needs to be able to manage a team. He or she must also act like a project manager and knock on the right door to get the funding for this or that project. And maybe also support community professionals and help them define exactly what they're supposed to do. So more than a boss or a director, we need a coordinator. And I believe that that person will play an essential role because he or she will put some oil in the gearings and make sure that everybody gets to work together peacefully. So we are training people. It's a new kind of job. And we are training people to become coordinators. We mentioned earlier the HESP, the school, the high school for healthcare professional administrators. And we are training now in the school people who will fit the profile as coordinators.
On s'éloigne encore du système de soins et qu'on se pose la question maintenant de la santé plus globale, environnementale, et les facteurs de risque qui vont lier à l'environnement plus ou moins direct, dans lequel on va retrouver l'environnement, le changement climatique, la santé animale. Comment est-ce qu'on appréhende ça? Jacques, peut-être?
Environmental issues, animal health.
Je vais aller dans votre sens. Je ne vais pas vous parler de santé humaine ni de santé environnementale. Je ne suis pas légitime et pas compétent. J'aurais pu vous parler de santé animale. Je suis légitime, mais je pense que ce n'est pas le débat. On n'est pas sur ces trois santé et interdépendantes, on est bien d'accord. Le travail qu'on fait les professionnels de santé dans le cadre du Covid est remarquable. Je comparais ça, cet été on a eu des méga incendies avec des pompiers qui ont déversé des tonnes d'eau pour éteindre un incendie qui n'ont pas réussi. Là on était sur une méga pandémie avec tous les problématiques que nous avons eu à gérer et ils ont été remarquablement gérés au mieux qu'on a pu faire. Maintenant il faut se poser la question de la santé au-dessus de tout ça. Et la santé au-dessus de tout ça, c'est la santé de l'écosystème.
Pour water on the fire. So we have to rise one level, rise to the social ecosystem level. What is a social ecosystem? Is it a town, a municipality, a district, a region? It's a group of people interacting together. And if we want to avoid another pandemic crisis, we need to think, okay, what exactly can we do together? What is our ambition?
Comment nous nous adaptons, le socio-écosystème pour éviter l'émergence d'une pathologie vectorielle type moustique ou même type tique, si vous voulez. Je pense que quand on se met dans ce raisonnement-là, personne n'a la vérité, tout le monde a un bout de la vérité. Il faut donc se mettre ensemble, il faut apprendre à collaborer ensemble. Et c'est là où les difficultés commencent. Alors, je dirais qu'il y a deux conditions avant d'être ensemble. Il faut déjà des acteurs sur le terrain présents. Donc je vous renvoie au désert vétérinaire, au désert médical, au désert électronique ou Internet. Tout ça, c'est important. Il faut que l'État soit dans les territoires, parce que sinon, il n'y aura pas cette capacité à partager. Mettons que nous soyons suffisamment dans un territoire et que nous pouvons partager. Déjà une bonne chose. Et là, il va falloir que nous apprenions les uns et les autres de nos compétences. Et si j'ai une certaine amertume en tant que vétérinaire dans ce cadre de ce Covid, c'est que finalement, ou à NELS, qui est le thème de la journée aujourd'hui, les vétérinaires vont pouvoir vous l'illustrer, mais plutôt dans ce qui n'a pas marché, ou dans ce qui a été pour eux une frustration énorme. Frustration lorsqu'il a fallu mobiliser les plateaux de diagnostic. Il a fallu 3 mois, 4 mois, le ministre a parlé de 3 semaines. Certainement, quand le dossier est mis sur son bureau, il a pris 3 semaines pour prendre la décision. Mais avant, il y a eu 3 mois de travail pour le faire accepter. Moi, j'ai en mémoire ce que le ministre de la Santé, en 2010 ou 2013, je ne sais plus, a dit à l'Assemblée nationale en disant « Chacun son métier, les vaches seront bien gardées ». Et aujourd'hui, on est bien à la limite du problème. Ce n'est pas ça le sujet. Le sujet, c'est comment, effectivement, ensemble, on garde les vaches avec nos compétences les unes et les autres. Et si je veux donner un autre exemple, lorsque mon confrère Thierry Lefrançois a postulé ou a été, je dirais, nommé à la commission scientifique, moi j'ai eu un coup de fil en tant que président de l'ordre pour essayer de voir quelles étaient les motivations, pourquoi, comment. Et on m'a renvoyé une image en disant le vétérinaire, il va
they told
s'ennuyer.
me, he's a vet, he will be
Pourquoi
bored.
a-t-on besoin d'un
Why do we
vétérinaire?
need a vet in a
Donc,
scientific
moi, ça
board?
m'a scotché, si vous voulez, comme
I mean, I was
réflexion.
flabbergasted.
Et on a parlé ce matin
Why would they say
d'antibiorésistance.
something like that?
Les
This
vétérinaires,
morning
on
we
l'a
were
dit, ont fait
talking
un super
about
boulot sur l'antibiorésistance
resistance
dans leur
to
domaine de compétences.
antimicrobials. Vets have
Aujourd'hui,
done a great
l'image que
job
nous renvoie un certain
regarding
nombre de médecins,
antimicrobial resistance.
alors, pas forcément sur le terrain, je vais pas dire que c'est dans tel ou
I'm
tel
not
bureau
saying
de
that in
la
this
rue de
or
Ségur,
that
c'est pas mon
office
problème.
in rue de
Mais
Ségur, people have
le
done a
message
great
qu'on nous
job.
renvoie,
But the
c'est que les
message
vétérinaires, finalement,
they are
ne
sending
seraient
back
que
to
la
us is
médecine
that
du Moyen-Âge
vets
de l'homme.
are like
Donc, il y a
medieval
à discuter avec des gens qui ne sont pas de niveau, si vous voulez. Moi, je
They
considère
feel like
aujourd'hui
they're
que la
talking to
médecine
people who
vétérinaire,
are beneath
elle
them.
est sur certains secteurs
I
en
believe
pointe
that
par rapport à la médecine
veterinary
humaine et
medicine is
le
actually
domaine du
ahead of
diagnostic en est
human
un
medicine.
exemple. Donc,
For
je crois qu'à un
instance, take
moment donné, il
diagnosis.
faut
In
qu'on
the
se
field of
connaisse.
diagnosis, we
On a
are
essayé dans les territoires, par exemple, avec la rage, on
doing very
discute entre
well.
vétérinaires et entre médecins
Rabies,
sur ce
we
domaine-là, puisque
with
quand
the
un
doctors
animal
regarding
mort,
rabies. Because if an
mort
animal
un enfant, par exemple,
bites a
il y a une
child,
surveillance
for instance,
sanitaire à mettre en
we
place.
need
Combien de
to
médecins ont le
start
réflexe d'envoyer le chien
rabies
en contrôle chez le
monitoring
vétérinaire pour
period, and how
effectivement
many doctors
faire en sorte
think
que
about
nous soyons
asking
certains,
that the
sûrs et
dog be
certains
sent
qu'il
to
n'y
the
a pas de risque de
veterinarian to make sure that the
contamination
dog
d'un
was
enfant
not
mordu.
contaminated
Voilà des choses sur
with
lesquelles
rabies and
il
would
faut
not
que nous travaillions
contaminate the
ensemble, il
child.
faut qu'on
That's
se
something we
connaisse,
need to
il faut
work
qu'on
about
accepte
together, work on together.
effectivement
And
la
we need to
différence.
accept
Il
the
faut
fact that
accepter,
we
on
are
a parlé de
different.
silos tout à l'heure,
People
de
talk about
sortir de nos
silos
silos
earlier.
et
We
puis
need
de
to
se mettre
accept
autour
that
de la
we're
table.
going
C'est
to
un
move
vrai
out of our
projet
silos and
pour
sit
moi
together around the
de
table.
territoire.
I mean,
C'est un
I
vrai projet
believe
de territoire
that is
et
a
le
real
départ du
project.
territoire, c'est qu'il faut quand même des
A
professionnels.
territorial project.
Parce que si vous n'avez plus de
And start a
professionnels,
territorial
vous n'aurez
project,
plus
you
de
have to have
santé,
people
plus de santé
there.
animale, plus de santé des plantes,
If there's
mais
no one
aussi
there
plus de
in a
santé
rural, deserted area, there will be no animal healthcare, human healthcare, or
Et puis,
plant health.
réhabiliter les vétérinaires en vaccinologie. Les vétérinaires ont eu un rôle fondamental.
In the vaccine domain, veterinarians have had a basic role since the 19th century. And one of the most beautiful books in vaccines was published by one of your Belgian colleagues, publishing everything about vaccines, which shows that a number of candidate vaccines led to works in human medicine. I was just trying to support your profession. Yes, and if I can give you another anecdote, because this is how you tell things best through stories. At the beginning of the COVID pandemic, we're about 20,000 in France. 5,000 called up the health reserve. But my right hand is enough to say how many were mobilized. And they was told, but don't say you're a vet, because people might be afraid.
Quelques points de discussion jusqu'à présent.
Well, I've noted a number of your
Cette notion de nécessité d'avoir une approche large,
this need to have a wide approach, not be focused only on care, for example, and think about wider than just human health. The idea of mobilizing very wide coalitions of stakeholders, the idea of rethinking primary care and the notion of professionals at the local level. One topic that came up several times, that of dialogue. We have to know each other, we have to develop a common culture,
et puis la notion de disposer des données et des analyses qui permettent de nourrir
having the data and analysis you need for the dialogue. Which leads me back to the question we had earlier. What is the role of the state in all that?
Jacques.
Parler par exemple d'environnement et l'État a un rôle réglementaire très important qui permet dans un certain nombre de domaines de diminuer les facteurs de risque.
Which will reduce the number of risk factors. For example, we talked for a while about the intoxication of children with lead. So now we have an obligation for paints, for example, and several elements. And this did not exist before, and the state has a role there. When you talk about environmental policies, the discussion on children's asthma, this is dependent on a lot of atmospheric aggressions that could be changed with a different transport policy, for example. So the state has a role to develop policies politics that can apply at national level, even international. But just talking about the national level, if the state does not make the right regulatory decisions and you can do whatever you want at local level, but it won't help. For example, endocrine disturbance. If you don't introduce a regulation, it's the same. You have to set the rules. After all, that's the role of the state. Yes, absolutely. The role of the state is to give a normative frame and also to guide funds so that
sur le transport, on change le
type d'investissement, changing the type of investment.
Et ce qui commence à se faire aujourd'hui.
And this is taking place now.
Quels qu'ils soient, sont souvent fléchés avec des objectifs qui sont beaucoup plus précis qu'ils ne pouvaient l'être avant, et plus exigeants sur le plan environnemental,
more and more dependent on some objective or environmental demands that may have an impact on health. And there's a third role of the state which is not developing today.
C'est à partir du moment où il fixe des objectifs, être capable de les évaluer,
c'est-à-dire de permettre the state has set objectives, it should be able to assess them, correct whatever is wrong, or support whatever is well done, to go even further. That would be a major role for the state, because if you don't want a state that does everything, they have to leave a position for local stakeholders and other stakeholders. So if you don't want a state that regulates everything from the top and from Paris, you need to have a state that assesses or supports the assessment here and there and say, okay, you're working in the right direction or you have to change this or that. And to do that, you need to have a real assessment policy, which is not the case at present. In a dimension
on sort un peu de notre jacobinisme, notre bureaucratisme débridé, et on accepte de lâcher la bride aux gens.
Huge bureaucracy,
donner des rendre responsables les personnes, savoir les accompagner et savoir les évaluer et être exigeant dans l'évaluation, puisque ça va plus on vous donne d'autonomie, plus on est capable aussi
the more autonomy you give people, the more you have to assess the autonomy, and then this would be a training.
L'intervention du ministre de l'Agriculture a été assez éloquente sur les axes politiques qu'il donne en termes d'agriculture, avec toutes les limites qu'on peut comprendre dans la mondialisation, l'Europe et toutes les règles. Mais déjà, l'État il fixe quand même des caps. Après, je crois que c'est vrai que c'est repenser. Il me semble que l'État, enfin, c'est peut-être le rôle de l'État, c'est de repenser un peu la santé publique à tous les niveaux, d'investir dans cette notion de santé publique qui finalement, ce que je disais tout à l'heure à mon collègue médecin, je disais, mais en fait, nous, moi, en tant que médecin généraliste, je rencontre des médecins de santé publique que dans les ministères ou dans des instances alors qu'en fait, ils devraient être tout près de nous, en quelque sorte. Donc, repenser ça, le repenser d'un point de vue de qu'est-ce qu'on y met dedans et comment on le finance. Voilà. Ils l'ont réfléchissé, donc, dans le cadre de France, c'était sur la notion d'un forfait santé publique, quoi. Un vrai forfait habité par des missions de santé publique dans lesquelles les médecins, en tout cas, ça pourrait être valable pour tous les autres professionnels de santé, les infirmiers, les pharmaciens, etc., pourraient s'investir chacun à leur niveau et avec une gradation dans l'investissement. Donc je crois qu'il y a un rôle vraiment très important là-dessus. Et puis je dirais, à mon avis, c'est toujours pareil, c'est une question de renversement. Je reviens tout à l'heure à ce que vous disiez, M. Valletoux, sur la question de laisser les acteurs de terrain. Il faut renverser un peu le système pour qu'il va favoriser l'innovation. Voilà. Je crois que c'est favoriser l'innovation et la soutenir là où elle a du sens.
Support innovation where it makes sense and then assess it, then you're okay. If I take the example of the eco-antibiotic plan, the state regulated, set objectives and empowered the stakeholders, i.e. the vets and the breeders. And in my opinion, the result has been remarkable today and is still remarkable. Another example about state policies is the issue of the presence of veterinarians in the territories and the network of veterinarians. So this is also a topic that applies to doctors. And the role of the state was to regulate and enable the local authorities to support people's installation and to organize a toolbox. Let's say we have a pilot phase and then we try that and we'll generalize it. And in the end, I believe and I agree that all stakeholders should be empowered in order to end up with a solution that will enable all animals to get taken care of.
Vous vouliez intervenir?
Laurence or
Jacques. Je pensais aussi à ce qu'avait dit M. Rousseau tout à l'heure.
Yes, coming back to what Mr. Rousseau was saying earlier, the health authorities can't do anything on their own. You have to include all the stakeholders, as Mr. Rousseau said, but you have to mobilize. Once the state has set a goal, you have to mobilize the local stakeholders because they're the ones who can get things moving, and you must give them a possibility to move on. I agree that you should support innovation and experiences and see what works and assess it, and if it works, all the best. If it doesn't, well, you generalize after that. And that's the way you make headway in health in general.
Je pense qu'il faut tenir aussi compte.
But I believe you should also take into account the experiences and the feedback.
Malheureusement ou heureusement, je ne sais pas, la crise sanitaire a permis de permettre des coordinations, des gens se sont parlé, ils ont travaillé ensemble, ils ont monté des projets ensemble. Le national nous a demandé de remonter finalement tous les projets qui avaient été
group projects at national level. We were asked to inform the central level about everything that was organized in the territories in order to draw the lessons from all this, because the crisis was also a way of experiencing things. If we can see some positive aspect to the crisis, it's a silver lining, really. And you can see the emergence of new organizations.
Pour la délégation au territoire d'un certain nombre de projets à partir d'impulsions nationales, on en a déjà depuis de nombreuses années. Pour ce que je connais, par exemple, la protection de l'enfance ou l'aide sociale à l'enfance et la PMI, c'est délégué au département
social support to children and PMI, mother and child protection. This is delegated to the territories, but for the moment there's no assessment of what is being done in the territories to see if there's a fair chance in all the territories, and we can see that it's not the case. First of all, because the populations are different, and also because some departments make a choice to give priority to one thing or other, for example, due to their political color, and you may have some inequalities that develop. So it's important to set the clear objectives. When a mission is given to you, you must have set goals and listen to the people in the field who talk about unmet needs. Marc, well, if the role of the state is to say what should be done, but it should also check that the systems do not limit some expressions, because this is you have systems that self-replicate, so to say, and the logic takes precedence over the reality. For example, if you look at associations in hospitals, they have a position that is not the one they should have. For example, we have huge problems, as you reminded us. We have a huge problem about medical demography that makes work almost impossible for many of us at present. But the state should get more structures to express themselves and sort of streamline more the associations with the hospitals in order to sort of so that the doctors can get rid of some of the actions they carry out, which are not theirs. Well, thank you for this fascinating discussion.